start. Actually, yesterday we just started some aspects of neuroanesthesia, and we just had a look on some of the key points and key concepts which are required for conducting neuroanesthesia. Okay, so we will just try to continue from there on. Just to change a bite, I will start with a small topic. What is Parkinson's disease? Yes. Who will take the lead? Rabia or Tayyaba?
Yes, sir. Assalamu alaikum, sir.
Walaikum assalam. What is Parkinson's disease?
Sir, it is a neurological disease in which there is degeneration of dopaminergic neurons in the substantia nigra of the basal ganglion,
Okay, so what is the result?
leading to tremors, rigidity, and bradykinesia.
Okay, what is different between Parkinsonism and Parkinson's disease?
So Parkinsonism may be precipitated by the drugs, but the Parkinson's
Just a
disease
second,
etiologies are not.
Zainab, just a second. I will ask you the question. Let this question be incomplete. I will just rain and the raise. Okay, thank you. Yes.
Sir, the absence or decrease of dopaminergic neurons is basically Parkinsonism disease, and Parkinson.
No, this is Parkinson's disease. Yes, Parkinson's disease. I'm sorry. So the symptoms and the syndrome which occurs is Parkinsonism, and Parkinson's disease is one of them. Okay.
Yes, sir.
This is the examiner can ask you this question. So they will be asking, there is a patient for any surgery with the known case of Parkinson's disease. So what will be so if someone asks you about Parkinson's disease, just say that there is imbalance between inhibitory neurotransmitters and excitatory neurotransmitters. Okay.
Yes.
Inhibitory neurotransmitter is dopamine. Okay. And excitatory is acetylcholine. So there is imbalance.
Yes, sir.
So when inhibited, so there is loss of inhibition, and resulting in what are the problems? What are the usual features?
So rigidity, tremors, and bradykinesia.
Okay. No, but practically, what are the features? They will ask. They would like to listen some of the names.
Some of the names.
Parkinson.
Cortical rigidity hoti hai. There is slow
lead pipe rigidity, cog wheel rigidity. Okay.
Sir, slow scanning speech, and also they have
micrographia.
Micrographia, and also they have a typical type of walk, which I forgot the name.
Fascinating gait. Fascinating gait. And this is the just like specific names which are being used. And what are the challenges for anesthetist?
Sir, challenges are that disease should be optimized.
No, this is not the answer to challenge.
Sir,
when someone challenges or concerns, challenges or concerns.
Sir, drug interactions are the main challenges for anesthetists.
No.
Airway management.
No.
No.
Like this is one of them, but if someone asking you about Parkinson's disease, autonomic problems, so the most important thing, autonomic problems, arrhythmias, and because too much secretions.
Aspiration.
Okay. So this is the main thing, and of course the drugs which are causing which can increase the symptoms, you will be avoiding anti-dopaminergic medicines. Okay. So they
interact with the dopamine and cholinergic balance, and also the medications and interaction of the drugs being used in the during anesthesia.
Okay. Another concern that the patient is taking the medications which are normally uncommon medications. Okay.
Yes, sir.
So usually what medications are patient is taking?
Patient is taking dopamine precursors like levodopa, and also dopamine agonists like apomorphine, morphine, and bromocriptine, monoamine oxidase B inhibitors like flagellanes, anticholinergics like orphanadrine, and also atypical agents like amantadine. They are also on COMT inhibitors, and these are the drugs which they.
If you just want to classify them, you will say either the medications which are increasing dopamine, or the medications which have anticholinergic.
Yes, sir.
Like you want to decrease acetylcholine, or you want to increase dopamine. So this is the main group. Okay, the main groups. Okay, so these are the main things. So you will be, if any surgery, you will be doing rapid sequence induction, but because of aspiration risk, but because with the rapid sequence induction, you can have patient suddenly can collapse. Okay, because of an exaggerated
autonomic instability.
And because there is restrictive lung disease pattern, so there can be some post-operative respiratory problem. Okay, and also there can be arrhythmias. Okay, and they will be at more risk of delirium, post-operative causes, post-operative cognitive dysfunction. So these are the challenges which you will have whenever you are. So you have to continue the
medication
medications.
till
You have to.
the time of the surgery, and restart them as soon as possible after surgery.
Okay, so can you give IV these medications?
Sir, these are not, most of them are not in IV preparation. The only drug which is available, the atypical agent amantadine in IV form. So if it's deemed important to continue medication, and if patient have very severe symptoms, then we can continue apomorphine in IV form preoperatively. And
you did not mention anything related to neurologist. Would you like to consult neurologist?
Yes, sir.
Okay, so you will be optimizing the patient from the neurologist. And what medication in what common anesthesia medications which you will be avoiding in these patients?
Sir, start from the induction, the antidopaminergics used for the antiemetics like metoclopramide, droperidol, and prochlorperazine. They should be avoided. Instead of them, domperidol should be used, which cannot cross blood-brain barrier. So it should be avoided. Pethidine or mepridine should be avoided because it can cause arrhythmias and muscle rigidity with selaginine. There is interaction of pethidine and selaginine.
What about what about the drugs which release catecholamines, like ketamine,
Yes.
and ephedrine? Okay, so you
They
will
should,
be.
and hypertensive sudden they can cause sudden hypotension, so they should be used carefully. Antidepressant like tricyclic antidepressants, they can cause arrhythmias, and also
Tricyclic, like this is related to antipsychotics.
yes, antidepressants.
Antidepressants are different. Antidepressants does not has any problems, because even the MAO inhibitors these patients are taking are not the typical MAO inhibitors. Okay, this is MAO inhibitors B, not A.
Yes, sir.
Okay,
B,
and yes, B for boy. And how will you compare? How will you compare regional anesthesia versus GA? If any surgery can be done in regional anesthesia, still there are some problems.
Sir, there are problems, but if we, it's again, it's on risk versus benefit.
No, but
there is
listen, even if there is risk, forget about risk versus benefit for a while. Of course, this is the, even if there is no problem, nothing. If patient is moving, so how will the surgery be done? Okay, like if for example, if you want, as we discussed that day in ophthalmology, cataract surgery, it cannot be done in local anesthesia. Okay, similarly, there will be problem in placing. There will be rigidity. So because of that, and this is one reason. Another reason is that sudden hypotension because of exaggerated autonomic reflexes. So this is otherwise like you can give it. It's not like contraindicated, but you have to be very careful. You can give peripheral nerve blocks if it is if any indication. Okay. So I think
if it's fully controlled, then we can go for it. But if patient is not fully optimized and the symptoms are there, then we should do general anesthesia with all the meticulous care about this kind of patient.
Yes. So actually this question, when they will be asking you in table viva, they will be adding some surgery with it. Okay. So there will be very limited margin of the knowledge which they will be extracting from you. So I will just summarize imbalance between excitatory and inhibitory, atypical medications, autonomic reflexes, problems related to aspiration and restrictive lung disease, and avoidance of the drugs which have anti-dopaminergic effect. That's what they will be expecting from you. Okay. Yes. And anything else will be related to the rigidity and post-operative care is required. There are chances of chest infection and because of exaggerated precipitation of the symptoms. Okay. So that's what you. So okay. So Zainab, first of all, Zainab will what do you want to ask or comment, Zainab? Sorry to interrupt you at that time.
कोई वो ड्रग्स के बारे में वो ऐड करना था वो डॉक्टर साहब ने ऐड कर दिया.
Actually we are now interacting only in English. Okay. So please try to communicate. Any question you want to ask? Okay.
No, it's all clear. Thank you.
Okay, Tayyaba, would you like to add something?
No, sir.
Okay. So just a few words about. Okay. So we will move on to the next small topic. Actually, it's not small. That is epilepsy. What is epilepsy, Tayyaba?
Sir, basically, this is a disorder of a brain. It is basically a disorder of the brain dysfunction, leading to the symptoms ranging from, you can say, the behavioral disorder to the life-threatening convulsions.
Like it is abnormal discharge. Abnormal discharge from neurons, because of abnormal discharge from neurons. Am I right?
Yes, sir.
So there are either the fits are focal or global. Okay, it can be even from area of like a small activity. It can be like there are multiple types of seizures. Okay, tonic, clonic. Okay, absence. Like there are different types, but usually what are the, like, if for example if you are anesthetizing a patient having epilepsy, so what are the important points you will be considering? Like the summary, what will be the basic thing which you will be looking at?
History of the patient regarding epilepsy, onset, the timing and the frequency, if the history of hospitalization, if any, and the medications which he is treating, and the last fit of the patient. These are the and also the drug history, full drug history.
Actually, you are absolutely right. But even more important than that, okay, fine. You'd say, for example, does it make
controlled or not?
For example, you are absolutely fine. But tell me one thing: if the patient has last fit 1 year ago, still would you not expect that there can be fit intraoperatively?
No, sir, we will expect that it
So,
can
okay.
happen anytime.
So that makes your answer a little bit different. That the most important thing is that yes, control and last is important, but most important thing is avoidance of all the factors which can initiate or precipitate the seizure activity. This should be your answer if someone is asking you this question. Okay, or precipitation of all the reversible factors which can precipitate seizure activity. Number one. And the other thing will be that what I was saying. I'm sorry, slipped out here. Yes, Mr. Itel, I will take your question first before I recall what I was saying. You have raised the hand. Would you like to say something? Itel A25. Would you like to ask something? Okay. So this is one thing, and but I was saying the second thing, the drug levels. They like problems. First of all, yes, actually this was the one which I slipped out, and the factors which decrease the seizure threshold. Thanks, Ruxana. So this is the important thing. That one thing is that all the reversible factors which can precipitate fits, and the things which decrease the seizure threshold. Okay, and related to medications, the medications has systemic involvement. So any end organ damage because of anti-epileptic medications like bone marrow suppression, liver dysfunction, renal dysfunction, it can be there. Okay, so this is important thing, and the drug levels. Okay, Tayyaba, and you have to anticipate.
Yes, sir.
And you have to anticipate seizure. Okay, and the main will be that the management will be different in different age groups. Okay, and the another aspect which they can ask you is the status epilepticus. We will be discussing it soon. And another very important thing. Okay, Tayyaba, you have to answer. How will you pick that there is seizure activity during anesthesia? Can you pick it?
No, sir, only via the EEG activity we can say that, while we can't pick it when you have given the neuromuscular blocker. No, there is no way.
There can be some, whenever there is epilepsy, there can be some changes in intracranial pressure as well, or no?
Yes, sir, but this will be, increased intracranial pressure can lead to Cushing's triad, a hypertension, bradycardia. But I don't think so that we can say 100% sure that the patient is in epilepsy or what.
No, you are right. You are absolutely right. But no atypical features, if they occur, okay, they can warrant. Like there can be hypoxia at that time because of overactivity. There can be hypoxia or autonomic response can occur because seizure activities, they are accompanied usually by exaggerated autonomic response. Am I right? So there can be some things which you can and for example, if you have not given muscle relaxant, okay, because neuromuscular blocker is not mandatory in every surgery. So if there is any surgery in which you have not given muscle relaxant, then you can pick it through raised airway pressures. There can be rigidity. Like if they are asking you, these are the things, but of course, the answer from where you started is the correct answer. That EEG is the gold standard, or because usually the patients, there will be two categories of patients: neurosurgical patients having neuromonitoring going on for neurosurgery, or any neurological patient for any other surgery. So it will be a little different in these two group of people, patients. Okay. So now a few words about what are the factors. Yes, Rabia.
Sir, one thing I want to add that during general anesthesia, apart from autonomic activity, we can monitor seizures activity with pupillary changes. So this I wanted to add.
Yes, it can be. Okay, it can be pupillary changes, but of course, as Rabia said, that there is nothing diagnostic or nothing we can say by conviction. Okay, like it's not by, yes, all these are the supportive things. If you are having a patient at risk, and now you are seeing sudden change in hemodynamics or anything, then you can confirm it with this pupillary change as well. Okay. So now tell me, what are the reversible factors which can precipitate intraoperative seizures?
So first of all, the drugs which preventable factors first of all are anesthetic. Some anesthetic drugs which can precipitate epilepsy or seizures. Are others some reversible or preventable agents are first of all talking about the drugs. First of all, talking about the preventable agents, which could be hypoxia, hypocarbia, electrolyte imbalance, hypoglycemia, and the decreased drug levels of the therapeutic drug levels of the anti-epileptic drugs. These can precipitate, and these are the preventable as well.
Hypoglycemia.
Also, hypoglycemia. Sorry, what I have told, sir, that was hyper?
You said hypocarbia. You did not say hypoglycemia.
Okay, hypocarbia, electrolyte imbalance, and hypoglycemia. Yes, perfectly.
What is the effect of hypocarbia? What is the effect of hypocarbia?
It decreases the seizure threshold, sir.
Yes. Okay. So at induction, actually, this can occur.
Do not hyperventilate the patient.
Yes. Usually we are hyperventilating, and this we do. Just a second, please. If you can mute your mic, please. Okay. So these are the general common things which you should be knowing. Okay. So drug levels and homeostatic conditions. If you use this word, that will also cover everything actually. Homeostatic conditions. Okay. You are if there is any stress, this can precipitate. Okay. And okay. So where
hyperthermia.
Yes. So when, if for example, if you were anesthetized, because during anesthesia, if patient's airway is already secure, you will try to and increase the depth of anesthesia or something like that. Okay. But if it occurs at induction or reversal, so what you can do?
Sir, at induction, before intubating the patient, if the seizures occur, then I will be going with an call for help and airway. I will check the airway if there is any problem with obstruction, breathing, and circulation as well. I will, first of all, I will want to decrease the intensity or stop the seizure by giving or sedating the patients by giving some sedative.
Just a second, Tayyaba. There is very important thing which you should mention when you are telling this airway, and that you have to prevent the tongue bite, because this is very common. Okay, and at least it should not happen when the patient is in hands of anesthetist. So you have to put airway so that to
bite block.
Yes, immediately. This is one of the. I'm sorry, by mistake. Yes. Okay. So yes, what else? Airway, breathing, circulation, call for help. 100% oxygen.
100% oxygen and bite block. And also, if there is a risk of aspiration or the vomitus present, then I would like to tilt the patient and also head down the patient. And then then I want to sedate the patient with the diazepam by giving some medication sedatives. And then I would like to secure my airway first by giving the by giving propofol or by doing RSI. I will like to secure the patient's airway. And then I will, after securing the airway,
just like I told you, this one bite block. And another important thing is that a patient, if you have jerky movements, patient can fall from the bed. So there should be a patient should be avoiding any injury to bones, joints. Okay, so this is also should be in your in your consideration. Okay.
Yes, sir. So then after securing the airway, I would like to check for the any precipitating cause, and I will rule out the cause regarding the seizure. And I will also like to talk to the surgeon about the
If it is,
urgency and emergency.
if it was at the induction, would you like to proceed with the surgery or no?
No, sir, I would like to liaison with the senior surgeon for this. If this is an emergency or elective, if this is elective, I would like to transfer the patient to the HDU for further management. And if it's urgency, then I have to. If it's selective, I know that I won't proceed it, but I
If
don't know if
emergency,
urgency
you
or
have to proceed.
emergency.
No, you have to
Okay.
proceed it. There is no question about it. Okay, you will just do the risk stratification. You can have, like, of course you cannot have EEG in a patient with non surgery, and it will not change your management. Okay, so you will just do the risk stratification and you will proceed with the surgery. Okay, you will proceed with the surgery, and you will just you did not do ABGs, you did not do check blood sugar. So you have to say in the same airway, breathing, circulation, disability, you can have these things. Okay, you can say that immediately I will send the samples for ABGs and electrolytes to see any correctable thing which you can do at that time. Maybe patient is hypocalcemic, patient is having any other change in sodium, or there are two categories of patient. One is having some known history of epilepsy, or there can be a patient who's not known epileptic. Okay, and maybe this is a cause, this is epilepsy is actually because of some neurological event which the patient has. So you will be thinking on that grounds as well. Okay, so you will have a neurosurgical consultation if it is not like that. And as soon as you optimize the patient, you will try to find out the cause of seizure. Okay, so maybe the patient need to be having MRI or CT scan, whatever is warranted. Okay, because it can be because of, and another thing is that which we have missed, that if patient might has received any medication at the induction, okay, which can have this problem, like this patient, you see when they are giving you this scenario, okay, they are expecting you to tell everything which can be the cause. So local anesthesia, systemic toxicity is one of the cause, so you have to tell, okay, that maybe you had given some regional anesthesia or alongside this one, so this may be the reason. So if in that scenario, you have to stop it and treat on the sides, on the line of local anesthesia, systemic toxicity as well. Okay, so because actually this is what is the oral exam, or even any exam, because you have to come out of the one book page, because it's not, these things which we are discussing is not written in any specific book. You have to scan and you have to think, only then you will be able to have a perfect answer. Am I right?
Yes, sir.
So among inhalational agents, what inhalational agent is most culprit, which is not
Enflurane.
Enflurane, which is not used now. Okay, so what about nitrous oxide?
So nitrous oxide can be used. I think it has nothing to do with the seizure activity.
Okay, what about IV anesthetic? Which agent is having some, like, which
Etomidate.
Etomidate,
Which we use in ACT.
Etomidate is actually myoclonic. Okay, it can cause seizures as well, but it actually, its main selling point is myoclonus rather than fits.
Seizures.
Ketamine, if it is used in high dose, it is epileptogenic, you can say. Okay, otherwise thiopentone is anti-epileptic.
Yes.
Anti-epileptic, and propofol has very strange that it decreases actually seizure threshold, but it is anti-epileptic as well. It is being used as anti-epileptic as well. Okay.
Yes, sir.
Okay, what about opioids?
Sir, the one the one sufentanil. No, alfentanil. Sorry, decreases the seizure threshold. Yes.
Okay.
It's alfentanil.
I think bethadine is contraindicated.
Pethidine is also. Pethidine and tramadol. Both of them are because especially pethidine, Pethidine has this one, norpethidine is the metabolite, which is proconvulsant. Okay, and tramadol, it is written that it decreases the seizure threshold. Okay,
But sir, it's alfentanil also.
alfentanil also, you are right. Alfentanil is also there in the list. What about, because that's how you should be learning. Okay, so we talked about IV anesthetics, we talk about inhalational agents, we talk about analgesia. What about NSAIDs, paracetamol? They don't have any problem, right? And
No, the neuromuscular blockers.
sorry?
The atracurium, neuromuscular blockers, sir.
Yes, among the neuromuscular blockers, what is the thing?
Atracurium because of the lidonosine toxicity.
Atracurium
But
not
it's not
in
proven.
actually no atracurium not in single dose or like that. Atracurium in high dose and
In high concentration.
continuous infusion. In that case, the lidonosine metabolite can accumulate and it has seizure threshold, seizure activity. Okay, so there is no other problem. Okay, what about you see there are some things which can mimic seizure. So what are those things? Like a patient is, especially this is the case in actually post-operative period. Okay, patient is aggressive, patient is delirious, then patient is hypothermic, patient is having shivering. So you can be distracted. Okay, at induction you are using saxamethonium, so it can mimic fasciculation. Okay, and what else? Ketamine actually also, not only because of its effect, but after ketamine, sometimes you cannot. Sometimes activity can occur like that. Okay.
The metoclopramide as well because of the extrapyramidal.
Yes, metoclopramide. Yes, metoclopramide. Any anti-dopaminergic drugs can also have dystonic reactions. Okay. By the way, what is the treatment for this dystonic reactions? Anyone?
So that's the no, that's the procyclidine.
Procyclidine.
Sir, dimenhydrinate antihistamine is given.
Yes, antihistamine. Dimenhydrinate is given. Okay.
So procyclidine is also given for this, no?
Procyclidine is what? I don't know. If it is there, maybe it's there. I don't know. Okay. Okay. So
yes, sir, it's written that extrapyramidal or dystonic reactions then treat with benztropine or procyclidine.
Procyclidine, I don't know about it. What is the group of procyclidine?
I don't know, sir. I have just remembered it in the MCQ.
No problem. No problem. Anyone can check it out.
Procyclidine is an antipsychotic drug.
Antipsychotic drug. So how can it? It will. I think exaggerate. It should.
It's the group in the anticholinergic or the antimuscarinic group, sir. It's the same as benztropine.
Okay. So it's like that. Okay. It can, procyclidine is used to treat the stiffness, tremors, spasm, or poor muscle control of Parkinson. But the question is that is this drug being used in acute attack? Actually, Tayyaba, this is I tell you something. You don't need to tell too many things. Okay. If someone asks you how to treat dystonic reactions, you say the approach will be airway breathing circulation because it can create problem. Okay, you will give oxygen and you will give dimenhydrinate. You don't need to tell too many things. Okay, because maybe you need to relax the patient as well. Okay, so I'm not sure procyclidine can be used in acute attacks or not. I'm not sure. Okay, that's written. So it can be reconfirmed. Okay, because these medications are being used as, like you can say that as a treatment, not as in acute attack. That's the question is this. Okay, I think it will be. I'm not saying that it is wrong. If you have read, it will be correct. Okay. Okay, so now some of the aspects about anti-epileptic drugs. What are the different groups of anti-epileptic drugs? Anyone else want to tell? Zishan, would you like to say anti-epileptics? What are different group of medications which are being used as anti-epileptic? And Rabia, be ready for status as epilepticus, both in adult and in pediatric.
Okay, sir.
Benzodiazepines are given.
Okay.
Then
You are very,
these,
you have to be
I
loud.
don't know the
We
groups
cannot
of
hear
these.
you. Zishan, we cannot hear you.
Actually, I'm traveling, so maybe the sound.
Okay. Anyone else want to say? Maybe your voice is better now. You can speak. You can speak. What are different anti-epileptic medications?
So ones are benzodiazepines.
Okay.
And then these phenytoin, carbamazepine. I don't know the further groups of these drugs.
Phenytoin, sodium valproic acid. Okay. Carbamazepine.
Lamotrigine,
Yes.
levetiracetam.
Yeah. You know, just tell me one thing. What is the basic mechanism of action? Usually, these medications.
So don't know exactly. I think this
Yes,
sodium
Tayyiba?
channels, something with the sodium channels.
Yes, sodium channels.
Don't know exactly.
And which anti-epileptics are used in anesthesia practice?
So levetiracetam.
No, anesthesia practice means anesthesia practice.
Thiopentone.
Okay, why? Fine, good answer. What else?
Which one, sir?
Midazolam.
Dazolam.
Okay, fine. You are telling the
Propofol.
medications which are actually not the selling medications for anti-epileptics.
Propofol.
Carbamazepine. It's used for trigeminal neuralgia. Okay. What about gabapentin? Gabapentin is used as preemptive analgesia and also used in neuropathic pain. Pregabalin and gabapentin. Okay. So all others are like the ones which are used common, phenytoin, okay, and valproic acid. So you should be knowing their mechanism of action and their side effects. Okay. And what is their effect in the liver usually? Usually they are enzyme inducer or enzyme inhibitors.
So they're enzyme inducers.
They are all enzyme inducers. Okay. What is the main side effect of phenytoin?
Anemia.
Anemia, sir.
What else?
Blood dyscrasias.
Okay.
Abnormal
Abnormal LFTs.
LFTs.
thrombocytopenia.
Yes.
Leukopenia.
Okay. Blood dyscrasias will tell everything. You don't need to tell separately. Okay. Blood dyscrasias will have everything, and the name which they say gingival hyperplasia. Don't you try especially if used in children of young age. Okay. And okay. What else? Valproic acid. Also,
abnormal LFTs.
yes.
And thrombocytopenia.
You know, if you forget, remember two things: bone marrow involvement and liver involvement. Don't forget these two things. Okay. If you majority of the, and the third thing is enzyme inducers. So carbamazepine, gabapentin, okay, benzodiazepines and thiopentone. Yes, but actually these are medications some of the medications which are used in the acute attack, okay, and some of the medications which are being used as the maintenance. Okay, so you can divide like that as well. And so you have to act like that. Okay. Okay. So what about status epilepticus? Just Rabia, what is the status epilepticus?
Sir, it is an emergency condition in which there is continuous seizure activity for more than 30 minutes or intermittent seizure activity for more than 30 minutes, not gaining a consciousness in between the activity.
Okay. So what will be your approach? In addition to the airway, breathing, circulation, we have discussed a lot. So what are the exact medications which are being used?
Sir, there are first line, second line drugs, and the drugs which are used in refractory status epilepticus. First line drugs are midazolam and lorazepam. And should I tell the doses as well?
Some of the, yes, just briefly.
Yes, sir. Sir, midazolam, we give.
If there is no IV line, what will you do?
Yes, I will give it IM. Midazolam IM 10 mg can be given once, or lorazepam 0.1 mg per kg IV or IM can be given. And if I will wait for 10 minutes, and if it's not effective, then the second line drugs would be used, which are phenytoin and sodium valproate. Phenytoin dose is 18 to 20 milligrams.
Just a second.
I think there is oxygen mask first before
yes,
the drug.
actually, actually, I intentionally skipped this point because we have discussed this thing. So I was just focusing on this thing. And in the same word, the important thing which you have to see, that you have to see the correctable cause. Okay. If you are thinking.
I was going to tell that. That's why I skip it, because you said.
Okay, no problem. Actually, there is confusion. I just, because we are we have taken a lot of time. Actually, I was thinking to finish these three topics in within 40 minutes. It's already 45 minutes. Anyways, no problem. So specific things which we have not discussed before is thiamine. Okay. In case of alcohol withdrawal. Okay. Yes, and hypoglycemia. So this is a thing which you have to say in this, that if there is some obvious.
Also, sir, we will send immediately after checking BSL, and we will take ABG sample and all this baseline as well, the drug levels. And
yes. So phenytoin, what else in other stage in addition to phenytoin? Phenobarbital.
Sodium valproate is the other option, and levetiracetam is the third option in second lines. And also we will consider advanced airway if it's the fits are continuous. And again, for second line, we will wait for 10 to 15 minutes. And if the seizures are not controlled, then the third lines, these are considered for refractory epilepticus. The options are propofol, bolus dose and then infusion, ketamine in bolus dose and then infusion, and phenobarbital.
Ketamine, no, don't say ketamine.
Sir, it's written.
I think unless the examiner is asking, because ketamine is not a common thing. Thiopentol, not ketamine.
Thiopentol, yes, sir, thiopentol, and then we will paralyze the patient and give the continuity.
You see, Rabia, what's the problem? It's written, okay, fine. But again, I will saying that it's not necessarily to say everything which is written, because if ketamine is a controversial medication, though it has practically it has nothing to do. If you are using in a low dose, it's nothing to do. But if, for example, unless he is saying more, he's asking you again, then you can say. Otherwise, don't tell it as a first go. You have told the same mistake you are doing, the same mistake Tayyaba does. That she also doesn't want to keep something in the mouth. She wants to say everything, and you also are doing the same thing. Just try not to reproduce the book, please. I request you people daily. Don't try to reproduce the book. They can catch you. I can tell you. Okay.
Yes, sir.
So what is difference in pediatric?
Sir, in pediatric age group, the first stabilization phase is same ABCD IV and check and blood sugar levels. In babies, we usually do not have IV lines, so we use the buccal, parectal, or IM dose of the anti-epileptic, like midazolam, diazepam can be used in those IM and buccal parectal form, and sir, if the seizures are not controlled, then second line, again, phenytoin and sodium valproate, phenobarbital can be used. And again, patient, if it's continuous refractory seizures, then patient should be intubated with RSI and shifted to ICU, and neurologist should be contacted for further management.
Yes, actually, you have told nicely. Only one thing which is different, which is written. Of course, you will be saying that now I'm saying that you are tell what is written, but they can ask you what is additional, which we don't use in adults. It's paraldehyde. Okay, paraldehyde, rectal paraldehyde is the one which it's not being used in adults.
Yes, of course.
Okay, so this is the only difference. And here you have to, if there is no, you will be preferring rectal route, because it can be absorbed, or buccal route, or rectal route. Okay, so otherwise almost the same. Okay.
Yes.
What about magnesium in others? Can we use it?
Yes, you see, if not with the typical medications, then we can have other things, other second associated things. Magnesium, because it's being used for epileptic fit as well. So their effect is the membrane stabilizing effect. So for that, yes, magnesium will be used. Okay.
Yes.
But actually, magnesium does not control the fits immediately. It takes some time. Okay. Even for epileptic fit, yes, we use the word load the patient with magnesium for treatment. Even at that time, we are giving diazepam or lorazepam. Okay. Or thiopentone.
Yes, first to control the seizures, first
Control the seizure, and then like you just have to shut down and then control. Okay, so this is you can say this will be the background music. Okay, this will be the background music. So among the epilepsy, we just try to cover in different aspects. We have to, because they will not ask you epilepsy as a disease. Usually they will be business end. They will be asking you what are the problems which are related to epilepsy. That's from where we started. I just went directly to the business end. What are the problems if someone told you the patient is epileptic? So you will see either it is controlled or frequent attacks. Even then, if it is controlled, you will be thinking to have the blood levels, and you will try to avoid the reversible factors. If it occurs, you have to manage it. You will anticipate. You will try to avoid the factors which can precipitate, and you will avoid certain drugs which we have discussed. And you have to see the acute causes of fits, like neurological problem, head injury, electrolyte imbalance, that you can correct immediately. Okay, so that's all about epilepsy. Anyone wants to add something, please? Anyone? Okay, so now we will go towards traumatic brain injury. Okay, so because actually I just because we were discussing the same this one cerebral physiology, so actually this is the same thing, but it will be the different in the management if it is in the form of head injury. Okay, and different from that. That's what we discussed yesterday about maintenance of cerebral perfusion pressure and everything. What will be different in here?
Sir, difference would be that again, we will deal the patient with the protocol of ABCD and ATLS guideline, immediately resuscitating the patient and looking for the cause. And there would be primary survey, and in primary survey, when we would be dealing with airway, then we have to be careful about cervical spine until otherwise it is excluded or ruled out. So
what will be the criteria for ruling out? Anyone know about? Just a second, Rabia. Just hold on for a second. I want to add. Just hold on. You are the mentor for this topic. Do you know? Anyone knows about nexus criteria?
So I don't know about the nexus criteria particularly, but the things which are to be considered is that the patient should not be unconscious. The patient should not be under an influence of any drugs or alcohol. He should not have neck pain, and there should not be any visible bruising or any signs of trauma at the neck. There were maybe 2 more points.
There is severe distracting pain, because if the patient has other severe distracting pain, maybe he's missing the neck pain. Okay. So okay, Rabia.
So is this the same criteria, nexus criteria?
Thank you very much. This is nexus criteria. This is nexus criteria.
Right.
Oh, okay. So Rabia, just take over.
Yes, yes. Sir, then I was where I was. Sir, in primary survey, when we were dealing with the airway, we would maintain the airway with rapid sequence induction with manual in-line stabilization and avoiding the injury to cervical spine. And after that, after securing airway, there would be some ventilatory parameters for maintaining maintaining and management of ICP, like mild hyperventilation.
You have Rabia, sorry. You know what? Actually, what I wanted you to say, you are telling right. But what I wanted you to say to start with my question was, what is difference in like maintenance of the cerebral physiology? Here you have to say that primary brain injury has been done. So all my management is heading towards prevention of secondary brain injury. It's the same thing, in the same thing, but different way. So this is one point, one most important point, number one. Number two, neck, as you told. And number three, this brain injury or this head injury can be part of generalized trauma. So you have to see and you have to follow the protocol of ATLS. Okay.
Yes, sir.
So this is the thing which you have to tell in your starting, because if you miss it, you will forget it. I told you. No, you used it, but maybe it was in such a way that it was not very visible. Okay. So this thing, whenever they are asking you the management of head injury, they are asking, because otherwise the same principle which we discuss, cerebral physiology, CO2, temperature, everything is alike. There is no difference, because that's why
cerebral perfusion pressure, in which in other traumas we maintain, we give the hypotensive resuscitation, but in this we have to keep the map above 80.
No, sorry,
so that
sorry. I'm just comparing it with any neurosurgical patient for craniotomy. Okay. So, but otherwise, all the parameters which are there for cerebral physiology, even that the prevention of traumatic brain injury is also the same. There is no difference. Same cerebral perfusion maintenance, same CO2 maintenance, same hypoxia prevention, same temperature maintenance. Okay. Same. There is no difference. Same maintenance of cerebral perfusion pressure, same maintenance of ICP, monitoring or management. Okay. Use of anything to maintain to decrease the cerebral edema, anything to control the sodium concentration. Okay. There is no difference, but they just want to know the word. And the last thing which I wanted you to tell, that this patient will be transferred from the emergency for CT scan, and there they will decide whether immediate neurosurgical intervention is required or not. Okay. So whatever you are telling, the main theme, if you have told these things which I have just mentioned now, again I will repeat: presence of other injuries, neck, prevention of secondary brain injury, and of course they will not keep the patient there. They will, after initial stabilization, they will shift the patient to CT scan. Okay. And if from there they will decide if there is any immediate decompressive craniotomy or burr hole or anything is required, they will do it immediately. Okay.
Yes.
Any sign of acute deterioration, an ICP or anything which is correctable with the surgery, they will proceed. So believe me, this is whole of neuroanesthesia.
Yes.
There is nothing else which is out of this context. Yes, there will be some questions which they will be asking you, and I would try to ask this question to someone else. What are the indications of neurosurgical consult if the patient is there? Okay. What will be the, like, when you would like to send the patient for neurosurgical consult? Who will be telling? Yes, Tayyaba, would you like to say? Anyone else? Just you can raise the hand. Anyone wants to tell? Like when will you say that this patient needs neurosurgical intervention? If there is fall in GCS,
Very rapid fall in deterioration.
It's okay.
And bleeding in the airway, and also
Similar question they can ask you, when will you advise CT scan? They ask this
Increase in
question.
cerebral edema, cerebral.
Yes,
Increased signs of the ICP.
just a second,
Increased
please raise
signs of
the hand.
ICP.
Yes, okay, Tayyaba, fine. What else?
Which could be in the case of pupillary dilatation are decreased, or absence of the direct light stimulation, or decrease in GCS, which could be in the form of one fall in the motor or the two fall in the total GCS, which could be in the form of the seizures of the patient. Even one seizure can also, even after one seizure, we would like to involve neurosurgical department. Or increased ICP signs, which is the vomiting or the pupillary dilatation, the significant deterioration of the patient. Others are.
You see, there are specific words.
Signs of-
GCS. Yes.
Signs of base of skull fracture.
Yes.
Like-
Sign of base of like
Rhinorrhea,
raccoon sign or battle sign. Okay.
battle sign,
Or
panda eyes,
CSF rhinorrhea.
hemotympanum,
And
fluid.
they say as you told, one sign decrease in sensory and then one in motor. I don't recall the exact word. GCS initially less than 13 or less than 15 after 2 hours post-in. Okay. So these are the questions which they can. Yes, by the way, a very simple question: how to assess GCS? It's very simple question, but sometimes it is difficult to tell.
In emergency via AVPU scoring?
AVPU is one of them. And what about GCS?
Just do the GCS.
GCS. Yeah, how to do it? Like
By
I will
motor
give you.
sensory and eyes.
There are 3 points, sir. Eyes, E4, V5, and M6. We see the motor response, we see the verbal response, and we see the eyes
Okay.
of the patient.
No, it's fine. But how will you number it? You see, this question can be asked in talks. They can give you a scenario, and they will ask you to calculate the GCS. So do the practice. I know that it is difficult to explain here, maybe, but this question. It looks very simple question.
Yes, sir. If the patient is opening eyes spontaneously, the E is 4. If he's opening on painful stimulus, sorry, if opening eyes on
Leave
verbal
it for a while.
response,
I'm
it's
sorry, leave
E3.
it for a while. I just wanted to give you a hint that this is an important question which they can ask you. It looks very simple, very easy,
Right.
but in talks you can fall. Okay, so because in there you have to be very calculative. They can give you a scenario and then can ask how to calculate the GCS. AVPU is the simple one which we use in ATLS. Okay. So this is just I want to tell. And what as I told that this patient will be transferred from emergency to what will be the criteria for transfer within the from emergency to CT scan or from CT scan to OR? Yes. Awake, verbal, pain, unconscious. If the patient is awake, it is A. If patient is communicating, responding to you on verbal command, it's V. If it is only responding on pain, it's P. And if it is not responding to anything, it's U. Okay, Roxana? Yes, Tayyaba?
Sir, there must be some protocols which must be met for the safe transfer of the patient, even in the intra-hospital. So first of all, I would like to communicate with the CT scan or the department in which I am transporting the patient, that the patient is coming for the CT scan. And the airway is secured. If needed, airway should be secured, and any life-threatening injury must be dealt before transferring of the patient. Now coming towards my personnel, which must be accompanying me, they must be fully experienced in transferring the critically ill patient, and the receiving team must be aware, as I have told earlier. Now about the equipment which must be accompanying me must be the monitoring equipment which must be fully charged, replacement batteries. The minimal monitors which I must be requiring would be ECG, SATs, BP, and blood pressure. ECG and SATs would be enough. If the captain available, that would be fine. Now about the infusion pumps and the ventilator. If the ventilator is moving, or I am moving with the ambo bag, then the infusion pumps must be adequately charged. The oxygen cylinder must be full, and one spares must be available.
Sorry to interrupt you. Sorry to just this point you just say that the time duration of transfer the oxygen should be double that supply time. Okay.
Okay.
It is true for all transfers because there is nothing much different even if you are transferring to other hospital. Okay. Usually these are the things which you have told in detail, that all the emergency equipment you have told in a very nice way, and try to again, if you don't want to forget anything, try to tell the things again in your background in airway, breathing, circulation, so that you will not forget anything. Okay, things related to airway, things related to breathing, things related to circulation, all the drugs and this and that which you have told.
Yes.
Only for oxygen,
yes.
You should be telling that the double the time you are anticipating, the double the oxygen reserve should be there. Ambu bag, even if there is ventilator working, you should have ambu bag as you told. Okay.
Yes.
So
no, sir, should I tell or?
yes. Continue, please.
Okay. Now for the drugs which you have already told that for the intubation, it could be the reintubation scenario. For the intubation drugs, emergency drugs must be there, anti-seizures drugs, and also the drugs that can increase ICP like mannitol or the diuretics. Fluids must be there. Now about, as the patient is of the head injury and trauma, I must be maintaining the general care of the patient as well, for maintaining the 30 to 45 degrees head raise. Neck must be in the midline and free from any tight ties.
Mills. They need collar, neck collar.
Yeah, maybe the hard collar or the
Yes.
other one is
Mills, like the collar, there should be
manual
collar.
inline stabilization.
Manual inline
Okay.
stabilization, and transfer should be very careful from the bed to the CT scan. That's because that's the thing which you can make up a temporary damage to permanent damage. Okay.
Yes. And I also want to call for the lift as well. So that there is the minimum time consumption between the transfer. So the lift must be there for the transport. That's it.
Yes, proper handover, proper communication. That's you told. If it is transferring to CT scan, the CT scan staff should be informed that the patient is coming, so that when we reach there, there is no waiting. Okay, they should be ready. There should be green signal from then before you transfer. Similar transfer from one hospital to other hospital. There should be telephonic communication, proper handover. The doctor which is accompanying, the nursing staff which is accompanying, they should be knowing. Okay, and adequate amount of oxygen and emergency. Actually, this is the same principles. There is nothing different, because some people are haunted by this topic. Unless there is air transfer, there are some things related to pressures in air transfer. Otherwise, the normal transfer which they can ask you within the hospital or outside the hospital, it will be related to these things which you have told. The patient should be stable, not with on many high inotrope, many or not on very high ventilatory settings. Okay, if patient, because the transport ventilator will not be able to have these things. Okay, like if patient is having high PEEP or special monitoring mode, special ventilator mode, patient will not be able to, it's not fit for transfer. Okay, so these are the things which you they then after that, either they will be sending the patient to neurosurgical, for ICU. Okay, maybe they are not doing anything, they are just keeping elective ventilation to control the ICP. There is cerebral edema, but there is nothing serious, so this patient will be shifted to ICU. Even in that scenario which you are telling, you can say that you will consult the ICU, that patient, there will be, even if the patient is undergoing surgery or no, you have to consult, book the bed in ICU. Okay, so these are the things which they will. So now before finishing, we will just talk something about the there are, it's already one. Okay, so trauma we will discuss separately. Okay, so with any question or anything related to neuro specifically, because there is one topic which I need to discuss before we finish. Yes, Tayyaba?
Sir, I want to ask you, what is basically, if someone asks me to describe what is ATLS, so the answer is there are basically 4 phases of ATLS, which
sorry, Tayyaba. I think ATLS we will discuss together. Trauma, the other aspect, other than head injury, we will not repeat head injury. Okay, because the people who are following us, we will continue from here, because that will be, that needs more time. So we will discuss the thoracic injury, abdominal injuries, role of fast, role of how will we approach it, because it will be. So I will just take a small topic. Anything related to neuro. Anything related to neuro.
No, sir.
There is a question. What about the central line? Which route we should be using? Yes. Is there any need of central line immediately? Is central line in the immediate care? Because in ICU you can have subclavian. Okay, because if there is collar, it will be difficult to take in the neck. Okay, and you don't want to move the neck, so you cannot take in the neck. So you can take subclavian, and it will be, because there is no, remember one thing, CVP is not for resuscitation. Okay, femoral is not recommended for like long term. Okay, because there are high chances of infection. Okay, so actually in the ICU, according to infection control and everything, the recommended site is subclavian. Am I right? Do everyone agree?
Yes, sir. Yes, sir.
Yes. Dr. Aman, MRI, I think the same principle which are applied to the transfer, and then all the MRI compatible material and all the concerns related to MRI, there is no contraindication for neurosurgical patient in MRI. Okay, so there's the same principle. In addition to that, all the concerns related to the environment, hypoxia, we will discuss MRI sometime. Okay, So the same principle. Before we finish, a few words about a very boring, actually it looks a very weird topic. What is awake craniotomy? Have you heard of it?
Yes, sir.
What is it?
Sir, which could be done in some blocks.
No,
And
this
the
is
patient
this is not the reason. This is the way. What will be the, you see, if someone asks you what is awake craniotomy, you will not say this thing. There are specific conditions or reason for doing awake craniotomy. The reasons are either anatomical,
about epilepsy.
surgery related to epilepsy. Okay, what else?
Just a minute, once.
What about Parkinson's disease?
No, sir.
I cannot hear you, Zishan. There is actually.
Sir, why someone wants to do awake craniotomy in Parkinson's disease and the patient is just moving?
Good answer. They want to identify the places. Whenever this is actually the reason is that whenever they want to see the response as if in awake. Okay. So in that scenario, they will just do the anesthesia as you told, that they will give a scalp block. Okay. And then they will use, so it is used for epilepsy. This is used for Parkinson's disease and certain areas in which you need to have the control, like you are checking exactly the places which you are approaching. Okay. So these
Sir,
are
also was in vitally important areas like Broca's areas, Brodmann areas in the brain.
There is a very difficult word, eloquent cortical areas. Okay.
Sir, yes.
There is excision of lesions from eloquent cortical areas. That, you know, I will tell you a story about it. That awake craniotomy, when I was preparing for the international exams, actually we had a group of people which we were 4 people, we were studying together. So my work was to arrange the topics. Okay. So I found in the article this topic, awake craniotomy. And my friends were very angry that what the hell topic you are bringing it out. And can you believe this? This awake craniotomy was there in our exam. Okay. FCI, when I appeared in FCI exam, they used to, that time they used to have the proper SAQs. Okay. So the whole of the SAQ was on awake craniotomy. So that after that, I was slapping them. Okay. I cannot tell what I said to them after the exam. Okay. So you see, actually, again, this is a very, very boring topic. The same of the thing which will be there, all the neurosurgical monitoring, everything will be there. So they will be asking you what is the reason for awake craniotomy, and there will be certain techniques for it. It will be like sleep, awake, sleep, or awake and then sleep. Okay. And they will ask you about scalp block. So what nerve are needed to be blocked for there are very strange supraorbital or infraorbital. It's pure rata. It's pure. Huh?
So may I?
Yes.
So 8 total nerves are blocked bilaterally. These are greater occipital, lesser occipital, greater auricular, auriculotemporal, zygomaticotemporal, supratracheal, and trochlear, and supraorbital.
So if you are not reading it from some page, I will clap for you. And if you are reading it from the page, then I will ask you that it is.
Sir, I have made a mnemonic for it. So
mnemonic for it. Okay, what's that?
Sir, that is very. I
Okay,
will tell
it.
you later.
Okay, so supraorbital, supratracheal, zygomaticotemporal, auriculotemporal.
If I I got the
just a second, leave it. Actually, I am like I just want to finish the main thing is that mainly it is from which plexus branches?
Sir, it's
The superficial cervical?
yes, sir. It's
from cervical plexus.
cervical plexus basically.
This is the
No.
superficial or deep is the approach to block it. Okay.
Yes.
And
It is a
and some of the branches from the cranial nerves also. What
yes,
about
sir.
this auricle? Huh?
Yes, you're right.
So supratrochlear is branch of ophthalmic nerve. Zygomaticotemporal is branch of maxillary nerve. Auricotemporal is branch of mandibular nerve. Okay, and the rest of them are from cervical plexus. Okay, and in that technique, there are a number of complications which can occur. The patient will be uncomfortable. Patient can have seizure when they are touching it. Patient can have seizure. Okay, the tube can be dislodged. Like all yes. So actually, the answer to this question or preparation for this question, if they ask about awake craniotomy, don't bob down. It is actually will be very easy to answer. They will be there will be like you know the best way which I learned from my friend, and actually he is my teacher, that rather than rather than reading blankly, try to figure out the questions which will be asked. Okay, so whatever topic you are looking at, you should not be cramming from the first line of the article to the last line and try to see what can be the questions. Okay, so because this is a atypical technique, so the first question will be why you do it, what are the reasons, in which patients you will be doing it, in what can be the problems, what will be the contraindications, what can be the sequelae, but like it's, you see, this is the similar to awake this one wake up test. Okay, and some of the things are common, like we do for awake carotid endarterectomy, okay, under local anesthesia. Some of the concerns are almost like that. Okay, so if patient is claustrophobic or he will not allow you, or you will be using a combination of it, and all the management will be hanging around the maintenance of cerebral perfusion pressure. Okay, so this is all about neuro. We try to cover it in as quick as possible. Okay, so I hope you people have got advantage. Awake patient when tremor near vital centers, motor, yes. Sorry, I didn't see you. So I will be very happy to take any question before we finish. And all of you are, I will request you that all of you, because it will be easier for you, just subscribe the channel and you see the playlists, because I am trying to put in the playlists, like before we had all the recordings were in our language. So unfortunately, you will not be able, the international audience cannot take it, but within few months, inshallah, we will be repeating it. So all the topics which we have covered in our language, we will try to cover in English as well. Okay, so subscribe the channel and look at the Parkinsonism. Okay, Parkinsonism, you see, Dr. Saad, the Parkinsonism was this balance between inhibitory and excitatory. Okay, and the main problems related to anesthesia is because of rigidity, because of autonomic problems, because of risk of aspiration and atypical medications, and avoidance of the factors which can precipitate the dopaminergic this crisis. Okay. Okay, Dr. Saad, is it okay? Okay, so we will finish our discussion here, and thanks a lot for your company. And the people who listen to the recording are requested try to join us, okay, and give the input, okay, and you can comment on the recording, so it will be better for everyone. And again, I say, because you see, I don't prepare a lecture, I don't, so I'm bound to do any mistake. So I will be very happy if I say something wrong and it is it's something, so it will be for everyone's betterment if you correct it, or you at least point it out that you have some other thinking. Okay, that because that's how we learn every day. If we close the door of learning, from there our decline will start. Okay, so thank you very much. Bye bye.